Hello, everyone. My name is David Sass, and I am a pediatric nephrologist with expertise in pediatric kidney stones. And we're going to be talking about warning signs for kidney stones in children and when to suspect rare diseases. This presentation is provided by P2P Syncro and is supported by an independent educational grant from Alnylam. So, kidney stones form in a particular urinary environment that starts with crystal formation, crystal growth, aggregation, and then adherence to epithelium. And this all occurs in a given urinary volume, urinary flow rate, and pH. Then there's this balance of inhibitors and promoters of stones that we have in our urine. And the list can get quite complicated, but how this balance turns out determines whether or not we form kidney stones. We like to dichotomize patients into stone formers and non-stone formers, but in reality, it's really much more of a spectrum. And we are all either likely to form kidney stones or not likely to form kidney stones. And a lot of that is determined by our underlying genetics. Our underlying genetics determine how at risk we are for kidney stones. So then beyond genetics, our experience with the exposome determines on a given day whether or not we form kidney stones. So what is this exposome? This might be a new term for you. So the exposome is the assembly and measures of all that one is exposed to through the course of a lifetime. These are generally modifiable things like diet, fluid intake, our microbiome, what medications we take, our underlying medical conditions, the climate we live in, and even our occupation. So putting it graphically, we have our genetics that we're born with, and then we have our interaction with the exposome, and this determines our state of health and disease. So how does this relate to kidney stones? Well, kidney stones traditionally were thought to be a disease of old men, right? That's the demographic that has the highest rate of kidney stones. But things are changing over time. We've done some studies and are finding that the rate of kidney stones in children is rising for reasons that remain unclear. But you can see in this graph, this solid black line represents the incidence of kidney stones in all children. And you see it's rising pretty steadily. The outlier here, this blue line up top, highlights how teenagers, our adolescent population, is where we're seeing the fastest rise. And if you break that down a little bit further, perhaps one of the most surprising things from this study was that this pink line represents our female patients. So we're seeing the fastest rise we're seeing is in female adolescents. And again, this is a departure for what has been traditionally thought of kidney stone disease in children. So let's talk about a typical patient that you might see in your clinic. A 9-year-old boy presents to your office with severe left-sided lower abdominal pain. The pain has been going on for hours and it waxes and wanes. He's nauseated, but he's afebrile and does not complain of dysuria. His urinalysis shows a specific gravity reflecting dehydration and a moderate amount of microscopic hematuria. So this case presentation, every word in here is specifically put in to highlight the most typical and classic presentation. And I want to highlight the fact that I specifically mentioned that he does not complain of dysuria. Many people are under the false impression that kidney stone pain includes dysuria. That is not typical at all. So dysuria should make you think of a UTI and maybe some other things, but stone pain comes from the stone passing from the kidney to the ureter, not from the stone passing from the bladder out through the urethra. So dysuria is actually, it can happen, but it's not a typical sign. But all of these other things, the waxing and waning pain, the very severe unilateral pain, those are all very classic for kidney stones. So sort of reiterating this, the classic pain is severe unilateral back pain, hematuria, often accompanied by nausea and vomiting. So that's, when adults have stones, this is almost always how they present. Kids, of course, they always like to throw us curveballs, so they can be a little bit more variable in their presentation. It can be classic. They can certainly present the same way adults can, but oftentimes they'll present with more vague abdominal pain as opposed to that very focused low back or flank pain. Sometimes they have no pain. They can look like this kid over here and just feel fine. And sometimes they have no hematuria. And sometimes they have fever. And I put the fever is in red because I want to highlight one of the important messages here, that if you have a patient who you believe has signs and symptoms consistent with stone pain and they have fever, that's a true urological emergency. That's a very quickly get to the nearest emergency department situation, because that can suggest stone passage with UTI, which can go sideways very quickly. So those are patients who need evaluation and management quickly. So how do we make the diagnosis? Well, it's usually made by imaging. And this can be done most typically with a non-contrast CT or ultrasound. You'll notice X-ray is not in here. In the 70s and maybe 80s, X-ray was used commonly to make the diagnosis of stones, but that's really fallen out of favor. And now we use non-contrast CT or ultrasound. So non-contrast CT, and by the way, we emphasize non-contrast because contrast, the addition of contrast will mask stones and make it very difficult to make the diagnosis. So pros of a non-contrast CT: it is the gold standard for diagnosis. It is the best way to identify stones and determine the size and location of them. The downside to CT is that it exposes children to radiation, which we like to avoid, and it is more expensive. For ultrasound, the pros are that there's no radiation and it's less expensive. The cons are that it is operator dependent and can miss small stones. So we argue about this all the time, about which is the best approach. When we go to our kidney stone meetings and nerd out about kidney stones, we will actively debate both of these. But for me, for children, I prefer to start with ultrasound. So, the caveat is, if you're certainly if you are at a pediatric center with radiologists and technicians who are well versed in pediatrics, ultrasound is great. If you're out in perhaps a more rural area at a community hospital where maybe they don't have that expertise, then you might start with the non-contrast CT. So neither answer is wrong, but I just want you to make sure you understand the pros and cons of each. So, but I described a patient with very, classic stone passage presentation, but there are other ways that children can present with kidney stones. Sometimes, in our evaluation of basic microscopic hematuria, we'll do an ultrasound and find stones. For sure, kidney stones can be a cause for hematuria, and of course, gross hematuria as well. Recurrent UTI. So these two, there's a symbiotic relationship. It's a bad relationship, but a toxic relationship, you might say. But there is a relationship between recurrent UTI and stones. So stones increase risk for UTI, and UTI increase risk for stones. So any patient where you've got recurrent UTI going on, you should have some concern for stones. And of course, we find incidental findings on imaging. I've seen kids who have had stones after they were in a car crash and had a CT scan, and lo and behold, there were stones. Or kids who were there was concern for appendicitis, and they find stones in the ureter. So it can be found just incidentally. And I also want to note that kids with renal or urological anatomical abnormalities are at higher risk for stones. So your patients with reflux, hydronephrosis, ureteroceles, any sort of anatomical problem from the kidneys on down can increase your risk for stones. So what about kidney stone presentations that suggest risk for severe genetic causes? Because we'll talk about the different causes of stones, and there's like all diseases, there are more benign versions of the disease, and there are very severe versions of the disease. So what are some signs and symptoms that make you think, oh boy, this kid might have something really bad that we need to evaluate quickly? So certainly young age of presentation. The younger the child with stones, the more likely they are to have a genetic cause. Large stones, right? So, most kids have stones that are 5 millimeters or under. If you see someone who's got, a centimeter and a half stone, that could suggest a more severe type of stone disease. The presence of nephrocalcinosis. So, nephrocalcinosis is calcification within the parenchyma of the kidney, as opposed to discrete stones, which form in the urinary space. But we know that nephrocalcinosis often goes along with severe genetic stone disease, and in some diseases is an independent marker for severity and progression toward kidney failure. So nephrocalcinosis should definitely get your attention, that this kid needs focused attention and concern for genetic stone disease. And certainly if they have stones in both kidneys or just have many stones, that should raise your suspicion. If they have elevated creatinine reflecting diminished kidney function, that can also be suggestive of more severe genetic stone disease. So these kids often present in the emergency department or in your office, and the acute treatment usually consists of IV hydration. You can use oral hydration if it's tolerated, but it usually isn't. Usually these kids are in so much pain and have nausea and vomiting that oral hydration is not an option. Pain management can be aggressive. So I know we're all very aware of the problems associated with opioids, but this is a case where you can start with NSAIDs and ketorolac, but opioids are often very appropriate and needed for these kids. They're in tremendous pain. We often will use expulsive therapy like tamsulosin, which can help relax the ureter and help the passage of the kidney stone into the bladder. And usually, by the way, once the stones get into the bladder, the passage going forward is often asymptomatic. It's just that journey from the kidney to the bladder that causes that terrible 10 out of 10 pain. Kids in your clinic or in the emergency department should be considered for hospital admission if they have intractable pain that's not manageable with PO medication, vomiting, obstruction if their imaging suggests that there's an obstruction going on, and as we mentioned before, fever. All patients suspected of having kidney stones or diagnosed with kidney stones on imaging should be given a method for stone collection. So this is usually a strainer. The ERs, almost all of the ERs will have these strainers, and the kids are instructed to pee through the strainer so that it will catch any stone, because analyzing the stone for its composition is super important for determining their underlying cause. So that's why I bolded that, because it always makes me sad when I hear that a kid was sent home without this and they peed their stone right into the toilet and didn't feel like reaching into the toilet to retrieve it and flushed it away. They've just flushed away very valuable information. And then what about surgical procedures? So, you can always consult with a pediatric urologist, and I strongly suggest for smaller children, a pediatric urologist. I've seen very many well-meaning adult urologists who instrument small kids with inappropriate instruments and inappropriate expertise, and that causes trouble. So even if you're calling, a pediatric urology center that's out of state, please do it. They're almost always going to be happy to talk you through what the next steps are and make sure the kid gets appropriate treatment. So we're not going to talk a lot about surgery because that could be a whole separate talk. But just understand, I just want you to understand the basic indications for surgical indication are stones, large stones. So typically, stones of 5 millimeters or less will pass spontaneously without intervention. That's not always true, but that's sort of what the research shows. If there's an infection, oftentimes that will require an intervention from a pediatric urologist. If there's renal dysfunction or inability to pass the stone for 4 weeks. So this is what the guidelines say, 4 weeks. That seems awfully long to me personally. I feel like most urologists, if a kid was symptomatic, would be happy to go in and intervene earlier. And certainly if the patient has intractable pain or nausea. So now let's talk about prevention. So that's my job as a nephrologist. My job is to figure out why you're having stones and come up with a plan for prevention. So the prevention, most of the details related to prevention of new stone formation depend a lot on the metabolic workup that we do to determine the underlying risk factors. But there are two things that are true of all stone formers, adult or pediatric. More water is helpful for prevention of stones, and reducing sodium intake is helpful for prevention of stones. So in order to increase water, I spend time talking to patients using this chart as a guideline, figure out how much water they should be drinking, and talk about specific ways to achieve that. Similarly, I spend a lot of time talking about sodium. It's really hard with our modern American diet to avoid too much sodium, but it can be done. Just take some education and diligence. And so we talk about ways to achieve limiting dietary sodium intake. So those two things are true of all stone formers: more water, less salt. I preach it all day long. So then beyond that, it's really about identifying specific risk factors for each individual patient. And I always do some blood work and urine testing, but the most important test that I do is the 24-hour urine stone risk analysis. So this is a list of a typical 24-hour urine supersaturation test or stone risk test. And there are a couple of labs around the country that do this test well. And as you're looking at this, you see there's a lot of analytes. So your brain is probably going to, I might need help interpreting this. Yes. So I use this slide to highlight the importance of referring to pediatric nephrologists and or urologists with expertise in stone care. And we are here to help. And your local pediatric nephrologist certainly will have some expertise with stones. But like every clinician, we all have our areas that interest us more or less. And so even if they don't, your local pediatric nephrologist does not have a specific interest and expertise in stones, they certainly can get the basics done and are almost always happy to reach out to an expert to make sure they're on the right track. So usually it's not the general pediatrician ordering the 24-hour urine, it's the nephrologist. And that's totally appropriate. And then they're the ones who usually will determine the specific risk factors for your patient and address them. I've highlighted oxalate here because hyperoxaluria, or lots of oxalate in the urine, is a common finding on 24-hour urine in stone patients, and something that should raise attention that maybe this is someone who has a rare genetic form of stone disease. We'll call back to this in a few minutes. So we talked about, in an earlier slide, talked about the clinical presentation that should make you suspicious for a genetic form of stone disease, like very high stone burden, meaning large stones, a lot of stones, bilateral stones, nephrocalcinosis, those sorts of things. But then, once we've done our complete workup, I just wanted to include this slide to show you how, sort of we go through this algorithm of who is likely to have a genetic cause for their stones versus an exposomal risk factors. So you can see these, we do measure all these things in the blood. And if we see them as abnormal, that raises our antenna to say, this kid has a higher risk of having a genetic stone disease. And then in the 24-hour urine, if they have hyperoxaluria or these other findings, these increase our suspicion. And parental consanguinity, right? So first cousins or closer who get married have much higher risk of, I should say who get married, who have children, have a much higher risk for having children with autosomal recessive kidney stone disease or other diseases. But then things that make us think, well, you know what, this might not be genetic. Usually our kids at high sodium diet, we see that in the urine. If they're just not drinking enough water, we see a lot of kids who barely drink any water. Other chronic dehydrated states, so kids who have chronic diarrhea for sure. If they have, we go through the whole blood and urine testing and they have favorable chemistry, that says, this might just be how they're interacting with their environment. And then there are medications, and antibiotics increase the risk for stones. Medications like topiramate, zonisamide, these can increase risk for stones. Kids who have seizures on a ketogenic diet That's increasing your risk for stones. So these are the things. Oh, vitamin D supplementation. So I see this a lot. It's very popular to supplement kids with vitamin D, but just know that supplementing with vitamin D increases your risk for stones through increasing urinary calcium. So that's often something we talk about in my clinic. So let's get into genetic kidney stone diseases. So I've included in this table, just as a reference, some of the more typical genetic kidney stone diseases that we see. And we're learning more. We're just publishing a paper now with our experience with genetically testing over 600 stone patients and what we found. And there are dozens of genetic stone diseases. These are just some of the more typical ones and the ones we know the most about. And for the remainder of this talk, we'll be focusing on the primary hyperoxalurias because primary hyperoxaluria is the most severe and in many and in certain types that we'll talk about treatable. So that's right. We always want to have a very acute awareness for these diseases that are severe and treatable. So here are some basic things about primary hyperoxaluria. It's a rare autosomal recessive genetic kidney stone disease. And it's an inborn error of metabolism in specific liver enzymes leading to overproduction of oxalate. So it's important to know that the key problem, the source of the problem in primary hyperoxaluria is that the liver produces massive amounts of oxalate. And that oxalate gets put into the blood and then is excreted through the kidneys. So the kidneys take the brunt of the damage here. And we get formation of kidney stones and nephrocalcinosis, loss of kidney function that in many cases progresses all the way to end-stage kidney disease. So end-stage kidney disease means you need dialysis and a kidney transplant. So this is very severe. And then perhaps besides the kidney failure, the most feared complications of primary hyperoxaluria are what we call systemic oxalosis. So this occurs when the kidneys can no longer excrete enough oxalate. It's overwhelmed, and the blood levels rise and rise to the point where oxalate is being deposited in many tissues across the body. So you can see almost every organ system can be affected here, and these oxalate deposits in all of these tissues can cause significant organ dysfunction. So there are three known types of primary hyperoxaluria, these genetic forms of hyperoxaluria, type 1, 2, and 3. And each one of them is caused by a different but related specific enzyme defect. You can see here in our registry of patients, type 1 PH or PH1 is our most common type. And then this figure here shows that it is also by far the most severe type. So what we show in this graph here, it's kind of a strange way to report it, but we talk about the likelihood of not reaching end-stage kidney disease. So basically, the steeper the slope, the more severe the disease. So PH1 is the line in pink, PH2 is in blue, and PH3 is in yellow. So what this shows us is that by far, primary hyperoxaluria type 1 has the highest likelihood of resulting in end-stage kidney disease. If you have PH3, you have almost no chance of ending up with end-stage kidney disease. And if you have PH2, the blue line in the middle, you're somewhere in between. So PH1 is the most common form of PH, and it is also the most severe, which is why the focus on developing a treatment has really been on PH1. So for treatment options, can we slow down PH1? Can we reduce the risk for end-stage kidney disease? Can we reduce the risk for kidney stones and nephrocalcinosis? Well, for decades, we had no really specific treatment. We just used the traditional treatments you see here with very aggressive water intake. So a teenager with PH1 would typically be drinking 4, 5, 6 liters of water per day. We almost always have these kids on a calcium oxalate crystal inhibitor like potassium citrate. So potassium citrate reduces the risk of calcium oxalate crystallization and aggregation. Then you see vitamin B6 here. So there's a subset of patients with PH1 who respond to supplementary vitamin B6. Vitamin B6 has an impact along the metabolic pathway for oxalate, and in a subset of patients can reduce oxalate production. And then finally, combined liver and kidney transplant. So obviously, this is a huge intervention. This is a life-changing intervention that requires lifelong immunosuppression and is very major surgery. So it's a big deal, but it is curative. When you remove the offending liver, PH1 goes away, and hopefully you put in a new liver that functions fine. But this is everyone wants to avoid having to do these major surgeries, especially on children. So luckily, we have some new treatments that are very effective, these novel siRNA treatments. So siRNA is a relatively new technology that disrupts the genetic pathway leading to the, in the case of PH1, the excessive production of oxalate. So lumasiran and nedosiran were developed to disrupt that pathway and reduce oxalate production. So we published the findings of this pivotal clinical trial a number of years ago for lumasiran, which is one of the siRNA treatments. And what the study showed was that there's a significant decrease in urinary oxalate. And that's really what matters. So we don't have a great way of directly measuring oxalate production. And that's what these siRNA drugs do. They reduce production of oxalate. But in terms of proving it in the study, we use urinary oxalate as a proxy for it. And what you see in this figure, and this is really the bottom line for lumasiran, is that we had patients with PH1 who received a placebo and patients with PH1 who received lumasiran as an injection. And their 24-hour oxalate went down by roughly about 65%. So this was a huge game-changing drug that gave hope to so many patients with primary hyperoxaluria type 1. This was in follow-up studies. Lumasiran was shown. This is in specifically in younger children, infants and young children. You see a very similar effect here. There was a drop in urinary oxalate that persisted over time. This last figure just shows in individual patients the urinary oxalate drop, and you see it's quite profound. So lumasiran was shown to be safe and effective for reducing urinary oxalate, and this led to FDA approval. Hot on its heels, nedosiran came through, and we did very similar studies here. And these figures just show, again, a very similar decrease in urinary oxalate in patients with PH1. So it's just really been wonderful to have these new treatment options for a disease that was very, very often severe and devastating. And so, patients and families and we as physicians are very happy that we have these new options. So, but this is the part of the reason for this talk is to highlight the need to increase awareness. We need people to know about these conditions that are severe and preventable, because there's a very nice, tragic, but not a nice publication showing what can go wrong if people aren't aware of this condition and don't look for it. So this case came out a couple of years ago, showing this was a 5-year-old who presented with end-stage kidney disease, and there was not a very extensive workup done because he had small kidneys on ultrasound, and they were calcified, but they were small kidneys, and they said, "Oh, this must be renal dysplasia. We'll do a transplant as usual." He got a transplant at the age of 7, and his new kidney that they worked so hard to get almost immediately failed. They did a biopsy, and the images shown here, you see these white spots. Those are calcium oxalate deposits. And they said, uh-oh, I think we missed primary hyperoxaluria. We're seeing calcium oxalate deposits. This is very consistent with PH. They did genetic testing. Sure enough, this kid had PH. They started him on lumasiran very quickly. And they were able to get this kid off of dialysis and regain some function, some meaningful amount of function in his transplanted kidney, and save the transplanted kidney. So again, I appreciate that these authors published this, because they kind of threw themselves under the bus saying we should have picked this up. But it's a great example to raise awareness and to highlight that this is still happening today, even with all the genetic testing we have available and accessible to us, and expertise out there. Tragic cases like this still exist. So just to highlight the importance, we need to continue to raise awareness about rare diseases. So some of the take-home points here. I want you all to know that kidney stones are becoming more and more common in children. So kids with abdominal pain or hematuria, you just need to have an awareness that stones are a likely possibility in kids with these presenting symptoms that we discussed. And that every child with stones deserves a thorough metabolic evaluation by an expert, early referral to a pediatric nephrologist, especially someone with expertise, is important, and that we should have a very low threshold for performing genetic testing in these kids, because we often find treatable diseases. And second, that risk factors for genetic causes for stones are important to recognize and act upon, and seek help from an expert. We are here to help. Many of us are very passionate about kidney stone disease and always happy to answer questions and provide guidance. And then finally, make sure that you understand that primary hyperoxaluria type 1 is a severe and treatable kidney stone disease that often presents during childhood. So we want to get these kids on these new available treatments as quickly as possible. That's what I've got for you. I appreciate your attention. Thank you very much.